Welcome everyone to the 12th Masterclass of Jaipur Surgical Tutorial. Jaipur Surgical Tutorial is an online education portal which was started by us at the Mahatma Gandhi Medical College and Hospital in Jaipur more than 3 years ago. The activities of JST are managed by my colleague, Dr. Anand Nagar, who is an associate professor of HPB surgery and liver transplant at my institution. Under the JST, we conduct online classes. We do a class every Saturday, 9 to 10 a.m. Indian time. And in these classes, the students present cases. Sometimes they present operative procedures, which are then moderated by faculty. Currently, we have more than 500 members, both students and faculty, as part of the Jaipur Surgical Tutorial. All classes are recorded, video recorded by the team of my former student and now a colleague, Dr. Avinash Tank at Dwarika Hospital in Ahmedabad. And all the recorded videos are available on the YouTube channel of Gastro University. If you put Gastro University or Jaipur Surgical Tutorial in the YouTube search, you will get to these videos. Now, in addition to this Saturday morning class, we recently started a Friday afternoon class, which was mainly at the request of students and colleagues in Africa, because they could not join the Saturday morning class. We did conduct some classes under this afternoon session also, but of late, the attendance and participation in these classes was not very encouraging. So we are kind of rethinking about it, whether to continue with that or not. And then last year, we thought that there are some topics which need focused attention. So we started these master classes, which are once in a month, last Thursday and Friday of the month, 7 to 9 p.m., 2 hours into 2 days. And we select one topic. So far, we have covered safe cholecystectomy, living donor liver transplant, acute and chronic pancreatitis, liver as well, ulcerative colitis, intraoperative bleeding, and so on and so forth. So today is the 12th masterclass, and the theme of this masterclass is abdominal trauma. And we think it's important because these are all young patients who, if they recover completely and get back to normal, productive life. And second, because this is something which requires a very intense initial resuscitation and very judicious decision-making as to what should be done and what should not be done. Obviously, we will not be able to cover the entire spectrum of abdominal trauma, but we've chosen two difficult parts, that is liver and pancreas. So we'll try to mainly cover liver and pancreas in addition to some general topics. And if anything is left, we will cover that in the open house session. So to moderate today's session with me is my colleague, Dr. T.D. Yadav, who is a professor of surgical gastroenterology at the prestigious Postgraduate Institute of Medical Education and Research in Chandigarh. I will request T.D. to moderate today's session primarily. And there may be a slight change or alteration in the sequence because my colleague, Dr. Anand Nagar, who is to present the grading of liver injury, is involved in the liver transplant, which is going on at the moment. So we will see whether he can do it on his time or whether we will have to reshuffle and he joins a little later. We are also very happy to have one of the senior most colleagues in India, Dr. V. Sitaram, who was retired from Christian Medical College, Vellore, but he very graciously attends all our online activities, and we would love to have some words of wisdom from him. And I'm very happy to welcome a colleague, Dr. Kamini Gunatilake, who's one of the senior army surgeons from Sri Lanka. He has huge experience with war trauma, and I have specially requested him to join the masterclass on abdominal trauma. And we will learn from his experience and his wisdom about these serious, especially blast injuries, during the open house session. I will request TD to please invite Dr. Kamini during the open house session to make some special comments. And we also will have, maybe today, but definitely tomorrow, Dr. Monica Gupta, a senior colleague from Jaipur, who has also offered to make some special comments on abdominal trauma tomorrow. So she will have a slot tomorrow. With that, I hand over to Dr. T.D. Yadav to continue to moderate the session. Maybe I'll introduce the first speaker, Dr. Subodh. He's senior consultant and professor at the prestigious Jayaprakash Narayan Apex Trauma Center, which is a kind of extension of the All India Institute of Medical Sciences in New Delhi. I think they, as a single institution, probably would have the country's largest experience with the trauma, and it's very befitting that Dr. Subodh has accepted my request to talk about evaluation of a patient with abdominal trauma. So over to TD for any initial comments, and then Subodh.
So, good evening, sir, and thanks for your nice comments. And as we always say that because of you, this continuous class is going on, and we regularly not only give our comments but learn a lot from these classes, from other colleagues and speakers from abroad, and even from the students. Even questions are very important for us to go ahead and read again. So this is a type of learning process for everybody, and lots of effort it put. So I will try to give comments later. But as we all know that abdominal trauma is in the, I was seeing the literature that in the fourth decade of life, the road traffic accident is going to be the commonest cause of death in a productive life, and abdominal trauma is one of the component after head injury and chest injury. The third very important component is abdominal trauma, and there are so many aspects of abdominal trauma. Trauma as such in our countries, it seems a little bit neglected, because what we talk about trauma, any trauma is when patient comes to our emergency, but trauma includes the moment person gets this type of injury and pre-hospital. I think one of his speaker would like to cover. I don't know whether somebody has taken it. That pre-hospital means that is where we are lacking. That how to initial management of the patient, so that patient reaches the tertiary care center or secondary care center and he is at least stable, at least bleeding something which is going on and on is stopped. Proper shifting, proper taking the patient from one place to another. These are the things which are done by the police personnel in abroad. But here in our country, I think this is very important component which is lacking. So with these comments, I will I invite Dr. Subodh, who is already sir has introduced, to give his this thing, and at the end we will, if we think that something more can be added or something can be clarified by Dr. Subodh, then we will give our comments. Dr. Subodh, please. Thank you.
Thank you very much, sir, and very good evening to the chair and all the participants. And I'm very happy that the JST has decided to organize online webinar on this very important topic on abdominal trauma. And I can't agree more on this. Yes, it's a neglected disease of the modern society, and especially in India. So a lot of work needs to be done in coming years to save these lives. And as Dr. Professor Kapoor rightly said, that the aim of managing a trauma patient, that he should be sent back to the society in a more useful and productive manner. So I bring greetings from my institute. This is the first standalone trauma center under the aegis of All India Institute of Medical Sciences, New Delhi. So it's a very, very important statement that abdominal trauma, any patient following trauma, if he sustains abdominal injury, it's a major cause of preventable deaths among multiply injured patients. And the most important cause of mortality in these patients is hemorrhage. And majority of these patients, they die at the scene without reaching to the hospital. And hemorrhage is, believe me, it's a preventable cause of mortality in such patients. And we need to recognize this hemorrhage, and we have to control the hemorrhage. We have to close the tap within the first few hours. And there is the concept of the golden hour. These patients, even if they don't make it to the hospital in the first hour, then at least we should try to make the time he reached to the hospital and convert into the golden hour. So because it has been shown that the moment you resuscitate these patients in the ED, it has a great bearing on the outcome. So let's start with the case scenario. So a 35-year-old male presented to the ED following history of fall from a motorcycle, following road traffic crash. He was complaining of pain upper abdomen. So what are the priorities in the early management of this patient in the ED? So unfortunately, we don't have a pre-hospital care in India, but we do receive in city of Delhi brought by the police in the PCR vans. Some of these are brought by the government-funded ambulance, the CATS ambulances. Some of them are brought by private ambulances, especially from other hospitals. Majority of these patients are brought by private vehicles. So we don't have a dedicated, robust pre-hospital care. But if you have, then this is the mnemonic mist. These are the things that you must know before receiving the patient to your hospital. It's a mnemonic which includes the mechanism of injury, injuries identified at the scene, what were the signs, the vitals at the scene, and what treatment he was given at the scene. In our context, it is relevant, especially if the patient is transferred from some other small hospital to a larger hospital. So this much information, if it is available to us, it will be handy and it will be useful in the further management of this patient. The moment we receive the patient, we don't know whether he has a chest injury, whether it's a head injury or it's a abdominal injury or a pelvic injury or a limb injury. He is a polytrauma patient most of the time. So based on his mechanism of injury, his vitals, the treatment administered in the previous hospital, various criteria, there is a form we have which is filled and we do the triage in the triage area in our emergency. And based on the vitals and other things like mechanism of injury, he is categorized in one of these three categories. And you all know that red is somebody is requiring a immediate care. He is having immediate life-threatening injuries. Yellow is that he has potentially life-threatening injuries, and green is walking and moving. Once we have done the triage, patient is rapidly assessed in the resuscitation bay, depending on his physiological derangements, which is the topmost priority over the anatomical injuries, and we provide a simultaneous resuscitation to these patients. And this is the algorithm which we follow in the ED. And the priorities do not change. And this algorithm starts with the primary survey. And primary survey is nothing, but it's a ABCDE examination of the patient. And I'll explain in subsequent slide what is ABCDE. And simultaneous resuscitation. The moment you assess that there is a problem with the airway, you have to tackle the airway and then breathing and circulation, so on and so forth. If your patient is not improving, you reevaluate the patient. And once you have done your primary survey, you have done your resuscitation, and patient has started improving, you move on to the detailed secondary survey. And the aim of the primary survey is to identify immediate life-threatening conditions, and these conditions need to be managed. If patient need to go to the OR for hemorrhage control, you don't have to go to the secondary survey. The aim of the secondary survey to identify potentially life-threatening conditions, then reevaluate, and then shift the patient for definitive care. He may require a neurosurgical care, he may require orthopedic care, or he may require a general surgery care for chest injuries or abdominal injuries. Priorities do not change, whether it's a pediatric patient or geriatric patient or a pregnant ladies or mechanism of injury. Priorities are same for all patients. As I said that during the primary survey, we need to concentrate on the physiological derangements of the patient. It is the physiology which kills the patient. If somebody has airway problem, he is hypoxic, he will die within minutes. If somebody has a breathing problem, he has a mass hemothorax or he has a tension hemothorax, he will die within minutes. So you need to identify physiological derangements during the primary survey And if your patient is not improving with your resuscitative measures, he is labeled as a non-responder, shifted to the OR for damage control surgery, which may include a damage control laparotomy, damage control thoracotomy, or damage control vascular surgery or damage control neurosurgical procedures without any further imaging and without doing any secondary survey. This is very, very important to understand. There are some adjuncts that one should do during the primary survey, but remember the primary survey is mainly based on your clinical acumen. And this is the primary survey. A stands for airway with cervical spine control. B is for breathing with adequate ventilation. C is for circulation with hemorrhage control. D is disability with brief neurological assessment with the assessment of GCS and pupillary examination and that whether this patient is moving all four limbs or not. E stands for exposure with environment control, or our EDs are air conditions. We are giving fluids which is kept in the shelf at 25 degrees centigrade. We are producing more hypothermia to the patient. Remember, there is a lethal triad in trauma, which includes hypothermia, coagulopathy, and acidosis. If all three are present, the mortality is near 100%. The aim of the primary survey is to identify immediate life-threatening conditions and manage them in right sequence. And only after this is done, proceed to the secondary survey. Till now we need to suspect the injuries region-wise once we have done the primary survey. The diagnosis, how to suspect that patient is having abdominal injury. There should be a high index of suspicion based on mechanism of injury. If somebody is injured in a road traffic crash, as you saw in the first slide, there was a injury mark in the epigastric region because of the handlebar. If somebody is in the motor vehicle crash, there is a steering wheel injury. Based on your clinical examination finding of the abdomen, as you all know, inspection, auscultation, percussion, and palpation. And there are some adjuncts that you can use during primary survey as well as during the secondary survey to diagnose abdominal injuries. So as I said, based on the mechanism of injury, you can suspect the blunt injury, like in this case, is a handlebar injury in the epigastric region. This patient actually found to have the pancreatic injury later on. This patient sustained a penetrating injury in the epigastric wound. And there are some adjuncts, as I said, during the primary survey. One is chest X-ray, which is always PA view and supine film, pelvic X-ray, because most of the time these patients sustain pelvic injuries which are diagnosed not clinically, then on X-rays, then all emergencies most of the time in a hospital, they have FAST. Using the FAST, they have ultrasound. So with using the ultrasound, we can do a FAST or extended FAST. FAST is nothing, it's a focused assessment with sonography in trauma patients, and DPL. DPL is nothing, it's a diagnostic peritoneal lavage, but nowadays it is not used with the advent of FAST because all the hospitals, they have a portable ultrasound machines available in the ED. Like this, there is an ultrasound machine in our ED bedside. There is a portable X-ray bedside to the patient, because remember, these adjuncts, X-ray chest, X-ray pelvis, and FAST examination should be done in the resuscitation bay itself. Radiology should come to the patient. Patient should not be shifted to the radiology department. This is the chest X-ray. I'm just showing how it looks like. It's always supine and AP view. Patient may have associated injuries, which are equally important along with the abdominal injuries. This patient has a pneumothorax who needs a ICD. But remember, this chest X-ray is not mandatory to decide about the need for ICD. If you think clinically that patient is hypoxic, SpO2 is less, decreased air entry, multiple fractures, there is a surgical emphysema, you can put a ICD even without chest X-ray. Pelvic X-ray, it's always AP view, supine film. If you are suspecting clinically, apply a binder, because most of these patients of the abdominal trauma, they have associated pelvic injury and vice versa. So pelvic X-ray is not must before application of pelvic binder. the immediate treatment of the pelvic fracture in the ED is application of a pelvic binder. Like in this case, you have seen this is a anterior posterior compression. There is a pubic diastasis. Another adjunct to the primary survey is FAST. FAST is focused assessment with sonography and trauma. It's an adjunct to the primary survey. It's a point of care investigation to be done by a treating doctor in the ED. You don't need a radiologist. Any doctor who is managing patients can be trained to do the FAST. It's an extension of the clinical assessment, and it is used to identify presence of intraperitoneal and intrapericardial free fluid. Remember, the FAST is not used to diagnose a specific organ injury. These are the few examples of the FAST. This is the FAST in the epigastric window to see the pericardial fluid. This is right upper abdomen, and you see the Morrison's pouch. There is a free fluid. Or you can do the left upper abdomen in the perisplenic area if there is a free fluid, or in the pelvis if there is a free fluid. This is the FAST. There are 4 windows in the FAST. And nowadays, there is a eFAST, which is done to diagnose pneumothorax and hemothorax. And here you can see if there is a lung sliding is present. There is a lung sliding present. It means at this point of time, patient is not having any pneumothorax. So while you are resuscitating these patients and evaluating these patients in the ED, these are very handy, and there are enough literature which suggests that FAST is very useful, and it should be done by the surgeons to evaluate trauma patients. And we have also confirmed the same in our center, and we have shown that FAST is very useful in trauma patients. Now, once you have done the primary survey, the further management of these patients and evaluation of these trauma patients with suspected abdominal injury depends on the hemodynamic status of these patients. Whether patient is unstable, then he goes to the OR.
Senior gastroenterologist at Jaipur.
Dr. Subodh, are you getting some?
Yes, somebody is speaking. Can you please mute that?
ED informs me that there is some mixing of voice
The
from
YouTube,
some other.
listening on YouTube, and that is what is coming up earlier this thing.
But I saw everybody is muted, so it is unlikely that it is from us.
No, there is somebody is speaking.
Continuous, it is coming continuously. Yes. Somebody is there is a disturbance.
Yeah, there is a disturbance.
Is it some other meeting which is
your meeting? You are introducing some earlier lecture where starting Nijhavar is the person. Yeah, you are introducing as you do in every talk. It means that recorded somebody is listening recorded one.
Oh, the previous
previous one.
The Dwarka team, can you please check why the previous video is echoing in our current meeting?
I know 175 publications you have written 2 books.
It's coming continuously.
Yeah, I can hear.
So once you have done the primary survey, and the further evaluation of these patients with a suspected abdominal injury depends on the hemodynamic status of the patient, whether patient is hemodynamically unstable or stable. If he remains hemodynamically unstable, he goes to the OR for damage control surgery. But if your patient is hemodynamically stable, then you do the further evaluation, do a secondary survey, which includes nothing but a brief history, which includes ample. Ample is nothing but it's a mnemonic, which includes the allergy, the history of any past medication or the pregnancy or past illness, the L for last meal, and E for events that led to these injuries. Overall examination of these patients, because now your patient is stable hemodynamically, head to toe, front to back examination to diagnose associated injuries. And once the secondary survey should be done, the primary survey is done, patient physiology must be improving, otherwise you reevaluate these patients. So after the primary survey, there are some adjuncts that you can use specifically to do the evaluation of abdominal injuries. And broadly speaking, we have 2 methodologies with us to diagnose abdominal injuries in a hemodynamically stable patient. I'm emphasizing again and again, the patient should be hemodynamically stable to undergo these investigations.
But Dr.
One
Subodh,
is,
if disturbance is diverting the mind,
yeah.
So I think
So once you have done the primary survey and secondary survey, there are some adjuncts which can be used for further evaluation of these patients with suspected abdominal trauma. One is CT scan and another is laparoscopy. So CT scan, what is the current protocol that if you are suspecting abdominal injury or a chest injury or a pelvic injury, we always ask for contrast enhanced CT scan of torso. And torso includes chest, abdomen, and pelvis. And it is very unlikely if somebody is having a chest injury that our part of the abdomen is covered by the lower chest and vice versa. And likewise, I said, if somebody is having a pelvic injury, likely he will have an abdominal injury. So always ask for CT scan of torso. There is no role of non-contrast CT scan, and I'll explain why. And do not ask for KFT in the acute setting. And in our center, our radiology, they don't ask for KFT before doing a contrast CT because patient will die of hemorrhage or pneumoperitoneum, that he will die of the renal shutdown later at a later date. There is no role of X-ray abdomen in trauma patients. Believe me, it's no use. Traditionally, when we were resident, we used to do X-ray of the abdomen erect supine. You can't make them sit or make them because he may be having a associated spine injury, and these X-rays will not give you conclusive information so that you can decide on the further course of treatment. So if you don't have the facility of CT scan, if you don't have even if you have a surgeon, it's better to refer the patient to a higher center. So it should be always contrast enhanced multi-detector CT scan of the torso is an optimal diagnostic modality for hemodynamically stable patients to aid the management of abdominal trauma, and no role of non-contrast CT scan. And it will give you information about the pneumoperitoneum, the solid organ injury, contrast leak, ongoing contrast leak, grading of the injury. And that is why the contrast enhanced CT scan is important, because unless you will know about the contrast leak, you won't be able to manage these patients. Associated meningitic injuries will be missed in a non-contrast CT scan. And of course, always ask for torso because you need to diagnose associated chest and pelvic injuries. And this is the one example of our own patients that if you do a single phase, it should be always a dual phase in a fast positive patients. If you do the venous phase, it's no contrast leak. In the arterial phase, there is a contrast leak. So there is a contrast leak pseudoaneurysm which was tackled by doing a DSA of these patients and doing the angioembolization. So that is why it should be a contrast enhanced CT scan dual phase in a fast positive patient. Now coming to the other modality in these patients is the laparoscopy. The laparoscopy can be used for diagnostic purposes most of the time. And sometimes if you have the expertise, it can be used for therapeutic purposes. So in a hemodynamically stable patient, you have done the primary survey, fast is positive, you have done the secondary survey, patient is stable, you do a CT of the torso, there is a solid organ injury. Most of the time, he goes for non-operative management. If there is a hollow viscous injury, he goes for surgery. But if the findings are non-contributory, equivocal findings on CT scan, then he is a candidate for laparoscopy, diagnostic laparoscopy. Remember, before deciding for diagnostic laparoscopy, ensure that he is hemodynamically stable. What is the rationale of doing the diagnostic laparoscopy? It has been shown that before the advent of this laparoscopy, based on the CT findings alone or even without CT, there is a high rate of negative therapeutic laparotomies in trauma patients to the tune of 40%. And that led to the wound-related complications like the laparostomy wounds and wound-related complications at a later date. So what are the indications of doing the diagnostic laparoscopy in current era? In cases of penetrating abdominal trauma, if you are suspecting intra-abdominal injuries, you are not sure whether the weapon has breach the fascia or not. If you are suspecting a diaphragmatic injury following penetrating trauma to the thoracoabdominal area. In cases of blunt trauma abdomen, if the abdominal injuries on the CT scan are not very conclusive, there is a hemoperitoneum without any solid organ injury. So you should wonder from where this blood has come. Most likely, it has come from the mesenteric injuries. These are the cases. If patient is stable, you can do a diagnostic laparoscopy and decide further course of treatment. These are the contraindications of doing a diagnostic laparoscopy. Patient is unstable. A clear indication for immediate laparotomy like frank peritonitis, hemorrhagic shock, or evisceration. And if you don't have the laparoscopic expertise in your hospital. This is our experience. We have published and we have shown that we could avoid 60% laparotomy by doing laparoscopy in trauma patients, both in blunt and penetrating injuries. Remember, if you are deciding to do the diagnostic laparoscopy, that both diagnostic laparoscopy and CT scan are complementary in abdominal trauma. Diagnostic laparoscopy may be performed without CT scan, especially in cases of anterior stab injuries. Never use penetrating wounds to create pneumoperitoneum. Hemodynamic status of the patient is dynamic in trauma patients. You have decided, but patient may deteriorate anytime. You should have expertise. There is a learning curve and always ready to convert. We did a comparative randomized control trial to compare the usefulness of CT scan of the abdomen and diagnostic laparoscopy in a stable patient with penetrating abdominal trauma. And we have published this RCT, and we have shown that there is a significant reduction in non-therapeutic surgery by using CT scan to evaluate patients with penetrating abdominal trauma. This is the algorithm which should be followed for imaging in patients with the abdominal pelvic injuries. So patient is having abdominal injury, is unstable, he goes to the OR. If he is stable, if there is a blunt injury, fast negative, but there is a dangerous mechanism of injury, go for CCT of the torso. If fast positive, go for CCT of torso. If there is a penetrating injury, fast negative, low velocity penetrating injury like a knife. If it is a posterolateral wall, just observe the patient, no further imaging is required. If it is a low velocity but anterior wall, you can do a CT scan of the torso and rule out intra-abdominal injuries, or you can do a local wound exploration in the OR, or do a diagnostic laparoscopy. But if it is a high velocity injury, whether it's a fast positive or negative, then if it is anterior wall, he goes to the OR with or without CT scan. If it is a posterolateral wall, then he goes for a CT scan of the torso with oral and rectal contrast. There is no role of NCCT. I am reiterating again and again. So I would like to conclude by saying that there is a take-home message that we need to have a high index of clinical suspicion of abdominal injuries in any trauma patient based on mechanism of injury. The ED management protocols are same for all trauma patients, irrespective of age, irrespective of gender, irrespective of mechanism of injury. FAST is a surgeon's tool, or any doctor who is managing trauma patients in the ED should learn to do FAST. It's a useful adjunct to the primary survey. There is no role of X-ray abdomen in trauma patients. If patient requires imaging, he is stable, he should go a contrast enhanced CT scan of the torso. Remember, the CT scan and laparoscopy are complementary to each other. Thank you very much for your patient listening.
Thank you, Dr. Subodh. And as sir was introducing Dr. Gamini Gunati Leke, and though I start with his valuable comments, so may I invite Dr. Gamini to give his expert comments about the whatever Dr. Subodh has presented right now. for evaluation. Any adjunct, any question, any comment, please?
Before you respond, I would request you, because you must have managed these patients where no investigation was available on the field. And that applies to small hospitals, small centers where patients are taken first. So we would be very happy to have your comments on that.
Do you want me to comment only on this subject or my general comments as well?
No, that we will do during the open house on the evaluation, the initial evaluation.
Yes. As regards the abdominal injury, 25% of polytrauma patients have abdominal injuries. 10% of those who have sustained missile injuries have abdominal injury, and 5% of them have pelvic injuries. In the management of abdominal trauma, it is essential to proceed in a stepwise manner, practicing the basic principles learnt in medical school, which sometimes, as we get older, we tend to forget. A detailed history, when possible, is very important to identify the cause of the injury. The other details, as mentioned earlier, include the time of injury, the time of the last meal, alcohol intake is very important. Past medical illnesses, drug and allergic histories are important in the evaluation, especially when the patients are going for surgery. There are several do's and don'ts, which has been mentioned, but I would like to emphasize and re-emphasize, especially the younger surgeons and the trainees. They must examine all regions of the body so that other injuries are not missed. They must not concentrate only on the abdomen. Practice the ABC of trauma. It is very important to make sure that the patient has a good airway. Stop the bleeding and restore circulation. Inspect, palpate and auscultate the abdomen for evidence of peritonism, hemoperitoneum. There is also something that sometimes we miss when we examine the abdomen. That is, we tend to examine only the anterior abdominal wall. But we must remember that we must examine the posterior abdominal wall, the flanks, the pelvis, the buttocks, the hip region, as well as the chest. As a medical student, I learned that half the abdomen is in the chest. And this part of the abdomen is covered by the rib cage, especially below the nipple line. Therefore, any injury below the nipple line would cause damage to abdominal organs, whether it is a penetrating injury or a blunt injury. There are several don'ts. We do not rush patients to the radiology department. I have seen this on many occasions. Patients who are in shock are being sent to X-ray departments. Today, because of FAST and EFAST, most of them can be diagnosed in the emergency department itself. Do not probe abdominal wounds. You might convert a non-penetrating wound to a penetrating injury and also cause damage and introduce infection. There are some patients who come with eviscerated bowel. There is a tendency to push this eviscerated bowel back into the abdominal cavity. This is something that should not be done, even if it's a small knuckle of bowel. And do not try to pull out objects which have been stuck in the anterior abdominal wall. That should be done only in the operating room, because there can be torrential bleeding if that is done in the wards. As regards investigations, it was mentioned a chest X-ray is very important. X-ray of the abdomen, I think there has some place, because we might be able to identify a fractured spine, and pelvis are very useful investigations. Today, diagnostic peritoneal lavage has been largely replaced by FAST, or focused abdominal sonography in trauma, which can be extended to the chest, diagnose hemothorax, pneumothorax, and hemopericardium. CT scans are usually done in stable patients. I have no experience in laparoscopy in the management of abdominal trauma, but I think it has a very limited value in selected patients who are stable and in centers where laparoscopy is performed regularly. There is also a place for angiography in selected patients and in excellent trauma centers. We should, if necessary, practice damage control surgery wherever necessary. Prolonging surgery and giving massive blood transfusions can lead to acidosis, hypothermia, and coagulopathy. Therefore, damage control surgery is very important. And for the junior surgeon, if there is any difficulty in controlling bleeding or managing these patients with abdominal injury, they must call for expertise before it's too late. before the patient goes into a state of shock, irreversible shock. There is also another condition that is called abdominal compartment syndrome, which also should be avoided, especially in polytrauma patients or in patients with multiple organ damage. They have hemorrhage, they have abdominal edema of the abdominal wall as well as the organs. Therefore, closing under the closing a laparotomy under tension should be avoided in these patients, because increase in abdominal pressure can lead to hypoperfusion, especially in the kidneys, leading to renal failure, hypoperfusion of the bowel and liver, and also decreased venous return. They can all lead to other complications. Therefore, in all these patients, it is better to do a laparostomy. Now, the time that I worked in Bhutan hospitals, we did not have these special Bogota bags and all these things to do a laparostomy. What we used was a urine drain bag cut to the required shape and then anchored to the edges of the abdomen with sutures after placing some saline soaked gauze packs between the bag and the bowel. And then at the time, and these patients have to be managed in an intensive care unit, sometimes with ventilation, close monitoring, and when they are stabilized, then we go ahead and do a suturing at the correct time so that they have no complications related to the abdominal compartment syndrome. I would like to stop there at the moment. If there are any questions or comments.
Thank you. Before we move on, TD, there is a question from Dr. Vihar Kotecha from Tanzania. Subodh, this is for you. He says that, what is your opinion about putting C before A, CABDE protocol?
So, if he's asking about the trauma, then till date it is ABCD and it will remain ABCD unless it's a combative trauma. And currently what we are following these protocols based on the ATLS 10th edition. Now the 11th edition is coming up, and I know the developments in the 11th edition. I think by next year or so, there is a concept of CA circulation before the airway only in combative trauma, not in civilian trauma. It will remain ABCD in civilian trauma. CAB, if he is confused with the ACLS protocol, in the ACLS, in the cardiac arrest protocol, there is a CAB where the C stands for compression, not for circulation. So, and that is only for unwitnessed arrest, the CAB is there. If there is a witness arrest in ACLS also, it is ABC and nothing else.
I think, TD, we need to move on.
Yes.
I will just introduce, because Anand is not there, as I
Sir,
said.
thank you very much. With your permission, can I leave?
Oh, sure.
Thank you very much.
Thank you. Thank you, Subodh.